Good evening. My name is Roxanne Chabot from RBC Consultants. Welcome to another International Dermatology Education Foundation educational series webinar. This evening, we're going to be talking about the importance of educating patients on topical corticosteroid application. Our moderator this evening is Dr. Leon Kircik, who is the president of the International Dermatology Education Foundation, clinical professor of dermatology at the Icahn School of Medicine at Mount Sinai in New York, Indiana University Medical Center in Indianapolis, and medical director of physician skincare, DermResearch, and skin sciences in Louisville, Kentucky. Our speaker this evening is Dr. James Q. Del Rosso, who is adjunct clinical professor at Touro University, Nevada, Henderson, Nevada, and research director principal investigator at JDR Dermatology Research in Las Vegas, Nevada, senior vice president of clinical research and strategic development, advanced dermatology and cosmetic surgery in Maitland, Florida, and president-elect of the American Acne and Rosacea Society. We'd like to thank our supporter, Primus Pharmaceuticals, for making this educational event possible. Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues or if you would like to submit a question to our faculty, please submit the question in the question chat pane on the right-hand side of your screen. At the end of this webinar, a survey will pop up in your browser and will be emailed to you within 1 to 2 days. If you could please fill it in and send it back to us. Finally, within 1 to 2 days of this webinar, a certificate of attendance will be emailed to you. Again, if you have any questions for our faculty, please submit your questions using the question chat pane on the right-hand side of your screen, and I put a little note there so you can see where to put it in. So without further ado, I will introduce Dr. Leon Kircik, who will talk to you about the International Dermatology Education Foundation.
Thank you, Roxanne, and good evening, everyone, and greetings from Louisville, Kentucky. So for those of you who are following me, I am back from Vienna. As you know, we did the last week's program from Vienna, and that was 3:30 a.m. Vienna time. So I'm very happy to be back on Eastern time. And as you know, International Dermatology Education Foundation is a nonprofit organization whose principal mission is to raise awareness and improve dermatologic care all over the world through education, especially in underserved areas. As you may know, since COVID, we have done a lot of programs, both in North America, Canada, US, as well as South America and Southeast Asia, Europe, and Middle East. So tonight, we are very lucky to have a good friend of mine, Dr. Jim Del Rosso, who's also one of our IDEF members. Basically, I'm the president of IDEF, and Dr. Del Rosso is the secretary, and actually, Dr. Firas Fougier is the treasurer of IDEF. So tonight, Dr. Del Rosso is going to discuss topical corticosteroids with a special focus, my favorite subject, vehicles. As we all know, vehicles do matter. So thank you, Jim, and welcome. Take it over, please.
It's certainly a pleasure to have the opportunity, Leon, to be involved, and I do want to congratulate you. I think the IDF has done a great job, and I'm always very happy to receive an invitation to participate, and Roxanne does a phenomenal job getting everything organized. So I have to tip my hat to you. There's a lot of work behind it. You know, you see these presentations and it looks like they just happen, but they don't happen without a lot of work. So we're going to be talking about topical corticosteroid application and really some caveats with regard to educating patients, because there's a lot of information out there that patients can get that for years they only got it from talking to other people, maybe a little bit in a newspaper or the Merck manual, if you remember that from years ago. But now they could get information from many different sources. A lot of it is very confusing to them, and topical corticosteroids is one of those areas where patients come in with preconceived notions, often scaring them about their use. And so that's one of the things we want to talk about tonight. So let's move forward. Okay. So go back here. We got a little bit of a finger. Okay. So this is what we're going to be talking about. Got a little bit of trigger finger. We're going to be talking about the current roles of topical corticosteroids in dermatology practice, where we are now, Corticosteroids is spelled with one S in the middle of it, not two. I just caught my own typo. That's embarrassing, but it happens. Now, there are non-steroidal agents that we've had for some time and some newer ones. There's a lot of information about these that come from different directions. And the question is, are they a friend or a foe? And really, any new therapies we have to think about as being collaborative as opposed to totally replacing things that we're already using. And we'll decide in individual patients what we feel is appropriate for them. So we're never throwing out the baby with the bathwater until there's absolutely a reason to do that. And there certainly isn't with topical corticosteroids. How do we use topical corticosteroids most effectively? And what do we need to tell our patients? So that's what we're going to be focusing on. And I'll ask Dr. Kircik to chime in. He knows a lot about this area, especially later when we get to some of the work on vehicles that I know he was very involved in. So what are some of the fundamentals? If we go back, topical corticosteroids, the first one was discovered and came to light in 1952, 2 years before I was born. So I grew up on watching how topical corticosteroids emerged in dermatology. It didn't take long before there was a discussion of the benefit versus the risk, looking at short-term benefit, which if you're utilizing an adequate potency for a certain disease indication, you can get significant impact in many disease states. Some take a little bit longer, but then there are concerns about the long-term use because of the adverse events, both topical and potentially systemic, depending on how widespread you're applying them. There are multiple compounds that have been discovered over time, and we know that the compounds individually have inherent potency. So for example, we know that clobetasol propionate is more potent than mometasone fumarate. And we know that that's more potent than hydrocortisone butyrate, which is more potent than hydrocortisone. Inherently, sometimes that salt can make a difference. Hydrocortisone butyrate is more potent than hydrocortisone. So sometimes the salt can make a difference. But then we have the vehicle that the formulation is in that also makes a big difference. And going back to when I was a resident back in the mid 80s and then going into the 90s and even probably around the turn of the century, right? There was a hierarchy that was based on what vehicle the particular compound was in. So if it was in a lotion, it was notoriously weak. So you can have something like fluocinolone in a lotion. It was going to be weaker than fluocinolone in the same concentration in a cream, and that was going to be weaker than an ointment. Because the way those formulations, those vehicles were made back then, there wasn't all the additives that we have now and all the advances that can take a compound and get it to deliver in a different type of vehicle more effectively. So there's been a definite change over time, and we've certainly seen that. But the hierarchies that were eventually developed with the different potency classes, and we all would get cards brought in by different companies that had products, or we'd see in textbooks that hierarchy of class 1, class 2, class 3, class 4, going down to the weakest, class 5. And in class 1 was the super potent, class 2 the high potency. We had different agents, different products that were in those different levels of potency that did fairly well with what we saw in clinical practice, and to some degree the greater risk of potential adverse effects, keeping in mind that even the lowest potency can cause those same adverse effects if you use them long enough, right? So that's an important part to consider. And that was reasonably a predictor of efficacy and safety, and a lot was based on the vasoconstrictor assay. That is an old assay. It was developed years ago, before all the advances in really looking at within the skin where the topical corticosteroids were actually going, which we could do now. So the vasoconstrictor assay, we'll talk about it a little bit later, was a measure where it was evaluated on the forearm. You'd put set amounts of the corticosteroid in a designated area, and you may be evaluating the same corticosteroid in different concentrations and in different vehicles, or different corticosteroids. And the observer would look at the degree of skin blanching. And this was based on the corticosteroid getting into the skin and causing constriction of the vasculature. Now think about where the vasculature is. There's the superficial dermal plexus, but a lot of that blanching is going to happen with vessels that are larger, that are in the deep dermal plexus at the junction with the subcutaneous fat, which is a lot lower than where you would really want that corticosteroid compound to be. So it really wasn't selecting out how the corticosteroid was being delivered and where. It was using basically something that was dependent on that observer, and that was how we evaluated topical corticosteroid potency. That's still being used today by the FDA, but there are some issues with it, and we're going to get into that. And that's an important factor to consider when you're looking at formulations. So we have different excipients that have changed the potency of topical corticosteroids. The hallmark one was the first super potent topical corticosteroid. If you could remember, it was betamethasone dipropionate, but it was augmented. It happened to be under the brand name of Diproline ointment. What augmented it? Very high concentrations of propylene glycol, higher than would even be in a patch test series. The propylene glycol could basically literally chew through the stratum corneum and the epidermal barrier and get high penetration of the topical corticosteroid. So it wasn't optimal for the skin barrier, but nobody was really thinking about that or talking about that much at the time. The focus was on getting higher potency, and they certainly did, and there were other formulations that became available. Think about going one step forward, clobetasol lotion, right? 50% propylene glycol. Took something that would be a very low potency because it was a lotion and made it a super potent steroid just because it had 50% propylene glycol. A fluocinolone formulation that went from class 2 to class 1 in a cream simply because it had 70% propylene glycol. So propylene glycol became the favorite to drive the corticosteroid into the skin, but it was certainly not optimal. We're going to talk about some newer formulations that have advances that don't utilize propylene glycol, which in very low concentrations can be a humectant, but in higher concentrations is not optimal for the skin, not optimal for the barrier, and there are certain other issues that have been identified with high concentrations of propylene glycol. If we can get the efficacy and use vehicles that are barrier friendly and have other advantages, that's the direction that we're going now, and there are examples of that. The other thing to think about, and I know Leon remembers this, early on with topical corticosteroids, and there are formulations we still have, like triamcinolone. Triamcinolone was approved for corticosteroid responsive dermatoses way back when with Aristocort and Kenalog when they came to market. Now it's available generically. We have chlorcotilone pivalate, which was available generically and was also a brand, right? That is approved, no age restriction for corticosteroid responsive dermatoses based on a package insert that is decades old with a different FDA. And now you move forward and we have agents that came along like mometasone. Mometasone is approved 2 years of age and older, right? So you started to see an age restriction. And then go fast forward even more recently to things like Desinide gel, Desinate, that's approved 3 months of age and older, but for atopic dermatitis. And we're now seeing agents, whether it's corticosteroid or non-steroidals, where the FDA is putting the disease state in there. They're no longer, in the case of corticosteroids, saying corticosteroid responsive dermatoses. That doesn't mean that these newer formulations aren't effective for these other disease states. It's just that the FDA has narrowed the definition based on the studies that have been submitted. But they're still corticosteroids, and they're still going to work where corticosteroids work. So that doesn't change, even though the indications may change. So I think that's an important background Leon, I'm going to stop there and see if you have any comments about that, because I know you're in that same age group as I am, and you might have some observations.
Well, thank you for letting me in. But I think, as you mentioned, one thing I'd like to mention that's important, how to differentiate or how we cannot differentiate the topical corticosteroid generics, right? The generics are made without absolutely any clinical testing, but with just the
Vasoconstrictor?
vasoconstrictor assay. Exactly. And unfortunately, most of us don't know that. Until I was involved with clinical trials, I really had no clue. But it's the only class of drugs that can come to the market without any clinical testing.
You know, we talk about, when you look about like at oral drugs or systemic drugs, it has to be within 20% of the bioavailability. But how do you test that on topical? Right?
Right.
So you don't really have a way to do that. You're not measuring concentrations like you do in the bloodstream. So I think that's an important observation. And I realize that there are cost implications, and patients have to be able to get a brand name that's prescribed for them. They have to have access. But with a brand name, no one can argue that you know exactly what you're getting. With a generic, you don't know what you're going to get switching from one formulation to another. So that there is a difference, you know, that's a definitive difference, and you can decide. Now, the question about topical corticosteroids being safe, you know, I think this has really been blown out of proportion in many people's minds. There's no doubt, if they're not used judiciously by someone that knows how to utilize topical corticosteroids, or by a patient that follows those directions, you could get into problems with prolonged use. Occasionally, we will see that in practice with stria, you know, erythema, you know, rosaciiform eruptions on the face, telangiectasias, problems in the groin area with chronic use of topical corticosteroids, sometimes potent due to the atrophy. The word has gotten out in the regard that all it takes is for a primary care physician, because they don't necessarily have the background, right? But if you go to the internet or you look at a package insert, a lot of these are blown out of proportion for the worst case scenario. But that's not what's going to happen when they're properly prescribed. So patients will come in with preconceived notions. They're concerned about topical corticosteroids. They heard they can thin the skin. When they were leaving a clinician's office, they heard, oh, just be careful how long you're using it. So they had these fears put into their head. And we're put in a position as the clinicians that know how to use them to overcome that in educating those patients. Sometimes they heard it from their hairdresser or their pharmacist, that they're often going to believe more than they believe us, unfortunately, and we have to work a little bit harder and just let them know to give us an opportunity to help them get their disease under control when they feel they need a corticosteroid, and we'll show them exactly how to use it. But that fear is real. They call it steroid phobia, which is a phobia is a formal psychiatric term for someone that has a true phobia, right? You know, someone that's afraid of heights, someone that's afraid of closed spaces, that really has a true phobia. We're giving that word discredit. People may have concern about using it because of what they heard, but it's not a phobia. We have to stop scaring people with the wrong terms. That's one of my pet peeves. I know Leon has some of his. So moving on, when we look at some of the heightened concerns, okay, with corticosteroids, okay, looking at the literature, these are 3 articles that focused on 3 different areas. One was an article, and these are all open access if you want to find them yourself, and there are other ones. It's interesting reading, right? These were parents of children with atopic dermatitis in Korea that focused on how the parents were fearful. The parents had heard things and had been given some education in their reading or different ways that they get information. The internet is loaded with all kinds of people and blogs and things scaring patients, that people that are not really in a position to give a full education, but they're certainly out there. Creates a lot of fear. Sometimes health professionals are doing it because that's what they have come to understand. Typically, it's not going to be a dermatologist, but non-dermatologists, in all fairness to them, they have a lot to balance, but sometimes the information is not good. So the parents are filled with fear. And then when you go over to the middle article, it talks about when there's a phobia or when there's this fear, it correlates with poor adherence. So if there's not an adequate understanding by the parent or the patient, the caretaker or the patient, of what's being done, that they have confidence that the corticosteroid is being used appropriately, they still have that fear in their mind, and they just don't use the medication the way they've been instructed to do it. So it really becomes important to us to let them know how important it is to use it the way we're telling them, and for the duration of time, and with the adjustment that we'll need to do. And then these patients are going to do extremely well. Okay? And then you look on the right, it talks about the phobia, and they utilize the scoring system to question healthcare professionals. And they found that pharmacists and primary care physicians were a source of that concern, of that fear, because they don't necessarily have the information we have. The pharmacists, especially in retail pharmacies, are getting those little handouts that they give that have all these fears built in that are not properly explained. So this can be an uphill battle. And when we take it one step further, okay, I'm trying to get this to move forward, okay. When we take this one step further, there's this other term that I want to caution you about. It's called steroid addiction and withdrawal. I see a lot of discussions about this. This is a far end situation that has to do with a small subset of patients that are utilizing corticosteroids, usually mid to high potency, over very prolonged periods of time. It was classically described on the face. Marvin Rappaport did a great review of this years ago to explain why patients get all this redness and this, quote, steroid rosacea, though it could be in other areas. This is not someone that you gave a topical corticosteroid and they used it, you told them 2 or 4 weeks and they used it for 8 weeks. These are patients months and months and months. So let's not take this term and let it transcend into all these other people being concerned, oh my God, I'm going to get addicted, or, you know, and I'm going to have all these withdrawal problems. This is when they have been used totally inappropriately over very prolonged periods of time, typically with higher potency agents, right? And that is really an important distinction. So there's a lot of buzz phrases and headlines out there. It's dangerous if you just read the headline and you don't know the details. That's how these problems happen, right? That's what the media takes advantage of a lot of times. They know you're only going to read the headline. So this is some tips on conversations with patients. And when I'm done with the slide, I'm going to ask Leon to chime in again, because I always love his input on these things. So I find that when I'm going in the room with a patient, and it's a patient where I'm going to be utilizing a topical corticosteroid, I may be utilizing it with other agents, certainly with skincare, maybe combining with a non-steroidal or transitioning. These treatments do not live in a vacuum. They're not fighting one against the other. It's all or none. We utilize things together in a variety of different ways, but topical corticosteroids are an important part of that armamentarium that we're utilizing here. I talk to them about it up front, because I have no idea if they have this stuff in their head. They're not necessarily going to tell me. Office visits don't go on for 3 hours. They can be relatively quick in some cases, or you don't necessarily get all the details. So I explain to them the rationale, and I make sure that they understand that there have been some concerns. I'm very familiar with using these. Use these exactly the way I tell you to use them, and I set a follow-up appointment that is early, so I could be watching them and helping them along usually it's going to be something I'm going to use for a week to 10 days. If an eczematous dermatitis, with psoriasis, it may be a little bit longer because it can take longer, but it's not going to be months. It's going to be 10 days, 2 weeks, 3 weeks. I want to see you back, and then we're going to adjust it. You're not going to have a problem if you utilize what I give you exactly the way I give it to you. And I control the quantity and the duration on the prescription itself. So if it's refilled inappropriately, it's the pharmacist that did it. It's not me. And I make sure the patients know that. And then let them know that we're going to incorporate other therapies. We may cut back on the frequency and always integrate proper skincare. The bottom line, Ron Hansen, who is one of the authors on a major pediatric dermatology textbook for years with Larry Schachner, he told me this one time, and I will never forget it. And so did some other people that are leaders, in this area. It's not how strong with a corticosteroid, it's how long. You can use a super potent corticosteroid just about anywhere for a short period of time. It's only if you're going to be using it over a prolonged period of time. And they're pediatric dermatologists, so they're using them on lower age groups. Now, I'm not suggesting just go out and give everybody a super potent corticosteroid, but the point is, it's how long people are using these. So you get into problems when there's not proper use of these agents. Leon, I'm looking forward to your comments. Right?
So you said it's not the strength, it's how long. It's so true. It's I was several years ago, I was at the Grand Rounds at McGill in Montreal, and they brought this lady in. I never ever forget. I wish at that time I didn't have a cell phone. I wish I was able to take a picture. The primary care doctor gave her some Desonide for her sebderm on the face, and she's been using it for years. And she comes in, one of the residents touched her face, and the paper, it was like the skin was cigarette paper, and it broke, it started bleeding. It was the most amazing steroid atrophy I have ever seen, but not from the strongest steroid. It's the weakest steroid that has been used over and over.
Sometimes people will be surprised that they say, how did you treat that? And I'll have a lichen simplex in the groin area of someone that's digging and digging and digging. And remember, we now tell women to use clobetasol for lichen sclerosis on the vulvar area
Exactly.
for weeks, which was heresy, remember?
Yes.
Right? You got to pay attention to it. You cannot be cavalier about it. But I would say, look, use this high potency, super high potency agent for a week, no longer. Look at me. You're not going to use it any longer. We get that agreement. And then you see them back. They're dramatically better. Then you could cut back. If I Mickey Mouse around with something that's too weak, they're going somewhere else because they never got better in the first place. So that's my view. It's like using too low a dose of prednisone for poison ivy. You give them 5 milligrams a day, nothing's going to happen, right? It's the same basic principle, right? So we're getting caught on the early end of this. I know we don't have all night, but I think this is all very important information. So let's move on to the idea that they're safe if properly used, and we have to turn it from topical steroid phobic to topical steroid corticosteroid informed. That's really our obligation. So things you should know. First of all, remember that topical corticosteroids, and I published a fair amount on this, and so did other people. There are other disease states than atopic dermatitis that have barrier dysfunction, right? That have epidermal barrier impairment, stratum corneum impairment. Psoriasis is one of them. Many other disease states are. So there's barrier dysfunctions that are beyond just transepidermal water loss and ceramides and things in atopic dermatitis. When you apply topical corticosteroids, because they're reducing inflammation, you can improve some of those barrier impairments with the disease, but it also can contribute to barrier impairment. That's the importance to utilizing good skincare, good gentle cleanser, and proper moisturization when you're using topical corticosteroids or even any other therapies in these patients. It's fundamental. But remember, the moisturizer is going everywhere. The treatment's just going on the diseased skin. So this is an example. This is from that second paper, not the one I wrote, the one Dr. Orsman wrote. It shows on the left, this is the skin barrier in a diagrammatic view. All the different components are working in concert to function with proper barrier repair. I mean, proper barrier function. Water permeability, the lipids controlling the water levels, the immune responses that are physiologic, the antimicrobial peptides that fight off organisms so our skin has a healthy balance and a normal microbiome. Then you see on the right, psoriasis. It has problems in the inflammation below, but it has problems within the stratum corneum. It has dysregulated lipid, corneocytes and lipid membranes. It has other agents with fewer tight junctions. So there are things that are going on in psoriasis over and above just all that cytokine elevation that we see, that dysregulation, where there's barrier impairment. So that's an important thing to recognize. And with topical corticosteroids, I'll make a long story short. This is from my publication. You see disease states on the right. You see atopic dermatitis and all the things we learn about. Not the right ceramides, and they're losing moisture, and they don't have antimicrobial peptides. But look below. Psoriasis has a long list of barrier impairments. It has dysregulations and problems in the lamellar bodies. It has some ceramide problems. It has some problems in some of the structural proteins. And when you look below, you can see here when you're utilizing beta-methazone valerate this is looking at it on atopic skin, that you have positive barrier effects from the corticosteroid, but also some adverse effects. So the point of this is when the patient's applying the topical corticosteroid, you're having some improvements. But remember, when they stop that topical corticosteroid, you are going to be leaving the barrier with some deficiency, because the corticosteroid has reduced lipid synthesis and has left some of those proteins not fully functional at the point of discontinuation. So it's important to be supplementing with barrier repair, with good moisturization. There happens to be a formulation called Episerum, which is really a prescription formulation that is really, I think, the sine qua non of having the balance of what the stratum corneum needs. It's not the only one. Nobody is saying it is, but it is formulated extremely well to work in concert with topical corticosteroids or in other situations where you need barrier repair. We'll be getting to that a little bit later. So this is the summary of the article. We have to remember that topical corticosteroids are important. They decrease inflammation through several mechanisms. That's the good. The not so good is they can impair lipid synthesis and also the bilayer membrane that controls water loss. And that's why when you stop topical corticosteroids and you don't support the barrier, you can sometimes see more frequent flare-ups, and people have observed that. So the skin care is integral with corticosteroids and even with other therapies, right? And we've seen that. This is a review, happens to be with eczematous dermatitis, but I think the same thing holds true with psoriasis, is that if you use good moisturizer and good moisturization and skin care, you could prolong the time to flares, you could reduce the frequency and intensity of the flares, and you could reduce overall your topical corticosteroid use, and maybe even the use of other agents so that they can maintain their skin better for a more prolonged period of time. There's good data to support this. Right? So now we're going to be looking at some advances in novel formulations. So here I'm going to talk about, and you see Dr. Kircik was on both of these posters. So he's a great person to have as a moderator because he knows a lot about this area. One of these formulations is a corticosteroid that is an emollient spray that's essentially a lotion. We called it a splotion. And it's a beta-methazone dipropionate in an emollient-like spray. which was under the brand name of Cernevo. It was reduced for a while, but it disappeared. It was introduced for a while, but it was disappeared because the company was no longer around. But it is available to us. We want to talk about the merits of that. And the point being, if your patient can get access, there's good reason based on the formulation and knowing what the patient's getting to consider this. We also have another formulation, which is a clobetasol propionate in a cream that is half the strength. And it's a branded formulation that's applied twice a day with topical clobetasol 0.025% as opposed to 0.5%, right? 0.05%. And so that's because of the DGME, the diethylene glycol monoethyl ether. Just remember DGME. This is an extremely important excipient. It's what brought Icahn to the market because it allowed Icahn to be solubilized and delivered in a very well-tolerated formulation without getting high systemic concentrations, but partitioning the drug in the skin where its anti-inflammatory effects were needed. It's also been used in topical roflumilast. That's Zoryve, and it's been very important with that particular agent because you want the PDE4 effects, but you don't want the systemic exposure. And it's doing it here in this particular formulation, which is called Impoise. So let's go through some of this. And we're going to talk about betamethasone dipropionate spray. It's a 0.05% spray. There is very high satisfaction by patients. It's very well tolerated. It's easy to spread. They like using it. That's covered in the publication on the right. But let's go further into what this formulation is actually doing. So when this drug was being evaluated by the FDA, they found that it was a mid-potency corticosteroid by vasoconstrictor assay, right? And that was consistent with the betamethasone dipropionate if you were utilizing it depending on the type of vehicle. If you were using in an augmented form, like some of the older forms, you would get a higher potency effect. But the vasoconstrictor assay has some limitations. What happens with the vasoconstrictor assay, as I said earlier, the examiner is looking at blanching of the skin, and that is basically after you get absorption, for the most part, through the areas of the skin where you want the topical corticosteroid to be active, where you're getting down to the lower dermis and the junction with the subcutaneous tissue. There, you're going to get systemic accumulation, right? And that was actually shown in some of the assays. So I'm not saying that we have to throw out the vasoconstrictor assay completely, but it is deficient in showing us where the corticosteroid is going and where is it being active within the skin. It was years ago when we didn't have these other measures to be looking at corticosteroids and what they're doing and where they're located in the skin, or even other compounds that we're studying like we can now. We have much more advances in the technology. So what they did with this particular formulation is they utilized excipients, right, where they were able to, and I'll show you how they did it, to get the betamethasone dipropionate to concentrate at a higher level than in those deeper aspects. So yes, it was able to get the mid-potency vasoconstrictor assay, but as I'll show you, in the clinical evaluation, it functioned as a high to super high. To be fair, let's say high potency agent, right? Because it sort of fell in that same zone, that between the high and super potent agents, higher than the vasoconstrictor assay. And the reason for that was because if you look on the left, you see on the upper right of that left-hand diagram, you see FA, FB, FC, FD, FE, and F10, right? Those were excipients that would be the solubilizing agent, surfactant agent that was put in there that would have a lot to do with the delivery of where the topical corticosteroid was going. So what you're looking at with those different colors was the betamethasone in the skin and where it was. So you can see, depending on which excipient you used, the concentration in the stratum corneum, the epidermis, and the dermis. The pink was felt to be too high, right? We don't necessarily want all of that there, especially since it's going to be there for a longer period of time. We want to hit in the middle, and we want it evenly distributed, because you have pathophysiology in the stratum corneum, in the rest of the epidermis and the dermis with this disease, psoriasis. And you do with atopic dermatitis also, which is not where it's indicated, but it certainly is going to be effective there as a topical corticosteroid. So they picked F10 because they saw that it had good concentration in all of the layers, right? And it's only going to be really toward the lower dermis where you're going to see that vasoconstrictor effect. You'll get some from the epidermis. And you're looking here, the permeation, how it's permeating into the skin where that blue fit, right? You didn't want that pink getting all the way through, then it's going to get into the systemic circulation. You don't necessarily want that. So they avoided that. Even though it may look like it's going to be better, it's going to go all the way through. So how did this pan out? In the vasoconstrictor assay, what you're looking at with that rectangular box on the left, you're looking at the betamethasone dipropionate spray, and its vasoconstrictor results fall as a mid-potency, and they matched up with fluticasone propionate and triamcinolone acetonide, which are mid-potency. So on the vasoconstrictor assay, they were lower than the augmented betamethasone dipropionate. So they turned out to be mid-potency. But look at the efficacy. Here you're seeing in the yellow, DFD was the betamethasone dipropionate, which is now known as Sinevo spray, when it was in its research name at the time. That's in the yellow. Then you're seeing the augmented betamethasone dipropionate lotion, which is high superpotent level for 15 days because the superpotents are only approved for 15 days. The betamethasone dipropionate spray, the Sinevo spray, can go beyond 15 days. But you're seeing here that the spray and the augmented lotion had the same efficacy, right? The spray was a little better at day 8, right? These are patients getting to clear or almost clear with at least a 2-grade improvement, but at day 15, they were the same. So the performance was higher clinically than what the vasoconstrictor assay would predict. And here you're seeing the data compared to the lotion with the vehicle spray and the vehicle lotion shows the same thing. And even if you went out longer with the lotion, you went out to a month, day 29, you got even further efficacy with more prolonged use, which is on label. So Leon, here's some examples clinically. I think they show, we're seeing here A, B, C, D, the patient on the left. This is with the betamethasone dipropionate lotion, spray lotion, day 1, day 8, day 14, day 29 with progressive improvement. And on the right, it's going to be tougher, right? It's going to take longer for something like this to improve. Even if you're utilizing clobetasol, you don't necessarily get everybody completely clear within a month. So I know you did a lot of work on this, so I'd love to hear your comments about this.
So actually, this was one of the few studies early on that they looked at difficult areas to treat, the elbows and the knees, if you remember. Actually, we might even have maybe a poster on this, but when you look here, you see the knee, and one of the most difficult areas to get better, to improve, and you see the improvement here, A, B, C, D. It's pretty amazing.
You get a good point, because a lot of agents that we know that are FDA approved for psoriasis, they excluded elbows and knees because it's harder to clear them. So that's going to elevate their potency in the assessments, right? Here, they did not exclude elbows and knees, a very important point, right? Any other comments? How about the vehicle itself?
Well, I think the vehicle is unique, right? We called it the splash. Actually, it's a spray, but it's a lotion in a spray. Now you can say, what's the big deal that it's a, it's a lotion in a spray, but it's very unique. We never have anything like this. And I think we all know that. Again, my line is vehicles matter. But in this case, it's important because for hair-bearing areas, for difficult areas to reach, it makes that spread very, very easy.
And when you have patients apply something in the office or thinking about applying it myself, if I'm putting a lotion on, a cream, doesn't matter, I put it on one area where it's going to immediately be on a higher concentration, and then I try to move it around. But depending on how that individual moves it around, there's going to be uneven distribution. A spray allows for more even distribution. So we'll move on to the next formulation, and this is clobetasol propionate 0.025% cream. I might have screwed up and said the concentrations differently earlier in my own head, but this is 0.025% cream versus the standard clobetasol. All the formulations, whether they're cream, ointment, are 0.05%. So it's half the concentration. But they were able to get, as I will show you, the same efficacy, but with less systemic exposure based on serum concentration and less HPA axis suppression. So I know a lot of clinicians say, I'm not worried about HPA axis suppression. Well, typically you're not going to be, but if patients are overutilizing the drug, they could certainly have problems locally and systemically. And that's what we want to avoid if that were to happen. If we don't need the serum levels, why do we want them if we can get the same efficacy? But how did they do this without propylene glycol? They did it going back to our friend DGME, diethylene glycol monoethyl ether. There used to be problems with this excipient because they weren't using pharmaceutical grade. So when impure versions were used, there were problems with irritation and other concerns. Now that pharmaceutical grade DGME is being used, non-irritating, non-allergenic, not carcinogenic, mutagenic, or genotoxic, and has this inherent ability to be very stable and to partition the active ingredient within the skin with very slow delivery systemically. So you don't get these high serum levels, right? And this has been shown, as I mentioned, with Dapsone. This has been shown with Roflumilast. And it was shown here with this particular formulation, which is under the brand name of Impoise Cream, which is approved for psoriasis. But once again, it can certainly be helpful for other diseases where clobetasol is helpful that are steroid responsive, right? So this is the information from the study on the upper left. You see that the 0.025% substantially lower HPA axis suppression, right, in the study, standard study. You're seeing here versus the vehicle, patients that achieve treatment success, day 8 to day 15, substantially higher in the patients that were treated with the active versus the vehicle, with an example of psoriasis on the right, twice a day for 15 days, and you're seeing significantly lower serum concentrations. So the point being, if you're going to get the same efficacy, but less systemic exposure and less potential risk of HPA axis suppression, and also able to explain that to a patient that has these concerns about corticosteroids that I mentioned earlier, it stands to reason that you'd want to have some familiarity with this formulation if you can get it for your patients, right? So this is an evaluation. It was a maximum use study. These were patients that had anywhere from 20 to 50% body surface area, right, that had psoriasis. The mean was about 27%. And whether they used the 0.025% or the 0.05% twice a day, right? It was a maximum use study, so a little bit over 20 patients in the study, but comparing both those groups, more than 50% in both of the groups got to at least mild from where they started. You can see here they had significant disease. You can see here the number getting to clear or almost clear, remember, they have 27% body surface area, and you're looking at only 2 weeks, you have about 17% versus 18%, the same in both groups, right? And remember, you're not going to get 30, 40% in 2 weeks when you have 27% body surface area with anything. So their efficacy in both groups was the same. And you can see a patient on the right, as Leon mentioned, elbow, right? So both of the formulations had equal efficacy. Right? So that was very, very impressive. Now I want to move on to something else that is sort of a little highlight that Leon and I like to talk about, and it has to do with radiation exposure. We see a lot of patients now that are getting radiation from radiation oncologists. Unfortunately, see a lot of women with breast cancer, other areas. We're utilizing radiation in our own practices, and I think there's really a lack of understanding, certainly amongst radiation oncologists, and they'll be the first to tell us that. You know, when the skin gets involved, we like to get your help, right? They're utilizing sulfadiazine from back from the dinosaur age because that's the only thing they know, and it never really has been shown to be significantly effective for the skin barrier problems that are related. They're trying to control potential infection, right? But what really has come to light based on this study is when you have patients that are getting radiation exposure, before you see visible evidence of radiation skin damage, erythema, radiation dermatitis, whatever you want to call it, there's been barrier impairment for several days before. You can see that on the right. The transepidermal water loss increase is significantly sooner than erythema, induration, and even desquamation and erosion. So once they start their radiation, give them a good barrier impairment cream. And that's one of the places where Episerum has actually been positioned. It's actually in its label to be signs and symptoms of these type of disorders, including radiation dermatitis. So it's an area where I try to get my colleagues to think about it. If you can get access to it, which there are good access systems, it makes a lot of sense to consider that in this particular situation. But now I want to get back to the topic at hand. I'm going to show you a few cases and then we're going to wrap up. I'm going to go through these very quickly because we're almost at the end of the hour. Right. So these were patients that were submitted from real world practice by an excellent dermatologist, Jason Smith in Rome, Georgia, to look at, it was some time back, how did clobetasol 0.025% cream apply twice a day behave or function in real world practice where patients were only utilizing that. They had been off of any other therapies. This was for psoriasis or eczema, eczematous dermatitis, mostly psoriasis. They had been off of other therapies for at least a while. They were not utilizing skincare during this evaluation. They didn't utilize cleanser and moisturizer on the affected areas because they wanted to see what this formulation, the brand Empoise cream, actually did. That's different than what you would do in practice, but they wanted to see specifically what this agent would do. So here's an example of a male who has psoriasis. All of these patients had relatively significant itching. You can see what he previously used and what happened at baseline to 2 weeks between the disease he had at baseline and at 2 weeks, and his pruritus was essentially resolved within those 2 weeks. And this is with the clobetasol 0.025% cream. This is on the dorsum of his thumbs. You can see here on the left, and as you go to the right in the same patient, you can see that he had actually complete resolution and significant improvement of pruritus, utilizing just that particular 0.025% cream formulation. Right. Here's a close-up of the same. Right. Now we're seeing a male salesman, moderate pruritus. You can see here on his elbows at baseline and at the end of 2 weeks, right? Had significant improvement and essentially a clear resolution. He had this on both elbows. So he was very pleased with those results and the itching improved. So this is once again with that half strength, if you will, clobetasol. And then moving on to a woman that had psoriasis on her legs that had a tremendous amount of sun damage. You can see here she used a variety of different things, non-steroidal agents, corticosteroids, even was on etanercept for a while. She had a significant amount of sun damage, and she had pretty severe, moderate to severe itching intermittently, where she would scratch at her legs and get excoriations, and that essentially resolved within the 2 weeks, and she was significantly improved. And there's a tennyson structure with nummular eczematous dermatitis that also responded. So these are just some clinical examples, and you might find this helpful in your practice. Here's that same patient with another area from baseline to 2 weeks with a nummular eczematous dermatitis, a question of whether she was atopic. So I am going to stop at this point, and hopefully this was helpful. A lot of information in a short time. Maybe Jim Del Rosso overload, I hope not. But Leon, let's get to some questions and see if you have any comments of your own.
There is
Remember,
never
if you
Jim
have-
Del Rosso overload. That was a very eye-opening lecture. I learned a lot. One thing actually I do want to mention about the clobetasol disconcentration. You know, what's the big deal if 0.025 versus 0.05, right? But I love the word that you use, the partition within the skin. And that actually reflects the permeation, right? And that's the key word. What's the best vehicle? It's the best topical is the one that penetrates, permeates, but doesn't get absorbed. So, so what's the big deal? Tell me about the half of the concentration of the regular clobetasol. How important it is?
Well, as I met, that's one of the questions we got. I saw in the chat that, it's the point that you can use a lower amount and get the efficacy that you want, and you can tell the patient they're going to get less exposure over the short amount of time they're going to use this. And in some of those cases that I showed there, I spoke to Jason about it. Some of those people were continued on intermittently. Maybe
Right.
they would use it once or twice a week with the chronic disease. They could go back to it, but they were understanding about not utilizing this the way you said somebody used the decenide over a prolonged period of time. So it's a controlled use, but it's a very effective use. And if you can get away with less of something and still get the benefit, I think that makes more sense to everybody, including the patient. Right?
Perfect. Now, it's great to have these products, the branded products that really separates themselves from the generics. But I also know it's very difficult. Access has become a big problem in this country recently. And I see here on the slide about the Primus Care Direct. Maybe you can tell us a couple of words, and then hopefully the audience can get some free samples by focusing on this by scanning this slide.
So when we have companies that come with branded formulations, they all have something that they're telling us a way to get access. Some of them are not very good at all. Some of them are pretty good. And Primus has one that appears to be something that is going to help a lot of your patients. You'll find out if you use it. And if it's not working for you, I'm sure your representatives at Primus are going to want you to let them know so they could see if there's a glitch or some way that they can help you get the medication, because they're very dedicated to want to make it available. If you go to this QR code on the right and hold up your phone to it, it will get you access to that information. But it's basically the information I have, and my staff helps me with a lot of this. We're taking care of patients or doing research, but it's important for us to be familiar so that patients can get what we want them to get. Primus Care Direct is fulfilled by Blink RX. It's a specific pharmacy, and it says here it's a trusted program serving covered CMS and uninsured patients to help you gain hassle-free access. And it's available for all 5 of their products: Cernivo, Impoise, Episerum. They also have Promaceb, Vasculera, and Rheumate, which are other products. We talked about 2 of the corticosteroids tonight, and we talked about Episerum. So I would suggest getting familiar with it and finding out the details. And hey, if I can get my patient a brand and it's hassle-free, I know what they're going to get. I'm familiar with it. I have data that I can talk to it. I can't talk to data with generics. Can't look at a patient in the eye and tell them this product we have data on. And I like to talk with data. and with experience. If even you don't even know what experience you're getting with the generics in most cases.
Well, we don't know which generic you're getting, right?
And it could
can be
change
also-
month to month. Now,
Yeah,
I'm not saying generics don't work, but we don't have the knowledge of what the patient's getting.
yeah. Unfortunately, the patients get generic du jour. Well, I have to stop here. We have on the top of the hour. I thank you so much. And I'd like to thank Primus again for supporting and creating this program. Thank you very much. Now
Thank
that
you.
we're done with the Primus program, please join us on November 28th next week on adult and pediatric patients expanding AD options, basically new treatment options by Dr. Raj Chavatiya. I thank you very much. I hope to see you next week on November 28th at 7 p.m. Good night, everyone.
Good night, everybody.